Welcome back to Pill Talk. Today we will focus on an important topic, heart failure. We will explore deep into its causes, symptoms, and most importantly, drugs used to manage this condition. Stay tuned as we break it all down in a simple, easy to understand way. So, heart failure, short form is HF, is a complex and progressive disorder. The heart job is to pump blood to meet the body's need, but in heart failure, it can't do that efficiently. So, this leads to symptoms like shortness of breath, fatigue, and fluid retention. Heart failure can happen because the heart has trouble filling with blood or ejecting it. As a result, abnormal blood volume and fluid buildup occur. So this means the body's organs are not getting the oxygen and nutrients they need. So its cardinal symptoms are dyspnea, fatigue, and fluid retention. Heart failure is due to an impaired ability of the heart to adequately fill with and or eject blood. So it is often accompanied by abnormal increases in blood volume and interstitial fluid. So heart failure is not a sudden condition. It develops over time due to issues like high blood pressure, coronary artery disease, or damage from a previous heart attack. Understanding these symptoms early on is a key to managing the disease. So now let's discuss the role of physiologic compensatory mechanisms in the progression of heart failure. So when heart failure starts, the body activates its compensatory mechanisms like sympathetic nervous system and the renin-angiotensin-aldosterone system, also known as RAS system. So this system try to help the heart pump more blood by increasing heart rate, blood pressure, and blood volume. Unfortunately, this compensation often causes more harm than good. It leads to changes in the heart structures like tissue remodeling, myocyte loss, hypertrophy, which is the thickening of the heart muscles, and fibrosis, also known as scarring. So this creates a vicious cycle that worsens heart failure if left untreated. That is why early intervention with medication is so important. So by targeting these pathways, we can slow down or even prevent some of the damage that these systems cause over time. Now let's discuss the goals of pharmacologic intervention in heart failure. So the goals of treating heart failure are straightforward but critical. So we want to alleviate the symptoms, means we want to make daily life more manageable for patients, and we want to slow down the disease progression, means to prevent further damage, and we want to improve survival rates, giving patient a longer and better quality of life. So the medication we use in heart failure treatment aim to increase the heart's ability to contract, reduce the workload on the heart by lowering blood pressure and fluid retention, and help the heart maintain a normal rate and rhythm. These treatments are personalized based on the severity of the condition. Some patients might need only one class of drugs, while others may require a combination for effective management. Now let's get into the different classes of drug used to treat heart failure. There are 9 main categories, and number 1 is ACE inhibitors, also known as angiotensin converting enzyme inhibitors. So they lower blood pressure and reduce the strain on the heart. Number 2 is angiotensin receptor blocker. Number 3, aldosterone antagonist. Number 4, beta blockers. Number 5, diuretics. Number 6, vasodilators, HCN channel blockers. These basically slow down the heart rate without affecting its strength of contraction. Number 8, inotropic agents. Number 9, Type-Natriuretic peptides. They are also used in acute heart failure to quickly relieve symptoms. So different drugs are chosen based on how the heart is feeling. For example, someone with fluid retention might benefit from diuretics, while someone with a fast heart rate may need beta blockers. As you can see in that image, all of the drugs are enlisted here: ACE inhibitors, angiotensin receptor blockers, ANRI, aldosterone antagonists, beta adrenoceptor blockers, and diuretics, etc. You can take a screenshot of that image, or you can take a screen snap if you are on a laptop. So let's move on toward physiology of muscle contraction, specifically related to heart. So the heart muscle functions just like other muscles, contracting in response to electrical stimulation. So in the case of heart failure, the contraction becomes weak and inefficient. The contraction force depends on the concentration of calcium in the cells. So that is why certain heart failure drugs work by increasing calcium levels inside the heart cells, which enhances contraction. This is also why positive inotropic drugs like digoxins are used in the heart failure. They help boost the amount of calcium available to the heart cells, allowing the heart to pump stronger. We talk about action potential in myocytes. Cardiac myocytes are electrically excitable, as I already discussed, and have spontaneous intrinsic rhythm generated by specialized pacemaker cells located in the sinoatrial and atrioventricular node. So cardiac myocytes also have an unusually long action potential, which can be divided into 5 phases, 0 to 4. Next is cardiac contraction. As I already discussed, the force of contraction of the cardiac muscle is directly related to the concentration of free unbound cytosolic calcium. So therefore, agents that increase intracellular calcium levels or that increase the sensitivity of the contractile machinery to calcium increases the force of contraction, that is also known as inotropic effect. Now let's discuss compensatory physiological responses in heart failure. In response to heart failure, the body tries to boost cardiac output through 4 key mechanisms. Number 1 is increasing sympathetic activity. Number 2 is activating the renin-angiotensin-aldosterone system. Number 3 is activating natriuretic peptides. Number 4, compensating for myocardial dysfunction. So if these mechanisms succeed, heart failure is said to be compensated. However, if they fail, the condition worsens, leading to decompensated heart failure, where symptoms become severe and unmanageable. So that is why treatment focuses not just on the symptoms, but also on addressing these compensatory mechanisms to prevent further damage. So acute decompensated heart failure. If the adaptive mechanism adequately restores cardiac output, heart failure is said to be compensated, as we already discussed in the previous slide. So if the adaptive mechanisms fail to maintain cardiac output, heart failure is decompensated and the patient develops worsening heart failure signs and symptoms. Typically, heart failure signs and symptoms include dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, fatigue, and peripheral edema. Before moving further, let's get clear about symptoms. Myocardial failure. It is the abnormality reside in the myocardium and lead to inability of myocardium to fulfilling its function. And what is a congestive heart failure? It is a clinical syndrome which is developed due to accumulation of the blood in front of the left or right parts of the heart. And what is circulatory failure? Any abnormality of the circulation responsible for the inadequacy in body tissue perfusion. For example, decreased blood volume, changes of vascular tone, heart function disorders. So now heart failure can be categorized based on which side of the heart is affected. They can be categorized as left side heart failure and right side heart failure. Left side heart failure can be further divided into systolic dysfunction, where the heart can't pump blood out effectively, and diastolic dysfunction, where the heart can't fill with blood properly. And right-sided heart failure occurs when the right side of the heart fails, leading to fluid buildup in the legs and abdomen. So both types can occur simultaneously, leading to what's commonly referred to as congestive heart failure, which is one of the more severe forms of the condition. So now let's move on towards drugs for heart failure. Let's start with ACE inhibitors and angiotensin receptor blockers. So these drugs are essential in heart failure management because they block the RAS system, renin-angiotensin-aldosterone system, lowering blood pressure and reducing fluid buildup. As you can see through this image, ACE inhibitors decrease circulating levels of angiotensin 2 and inhibit degradation of bradykinin, which has the 4 major effects shown. Number 1 is output of sympathetic nervous system will be decreased, and increase vasodilation of vascular smooth muscles, and decrease retention of sodium and water, and increase levels of bradykinin, which will ultimately lead towards the decreased preload and afterload, and that will lead towards increased cardiac output. Next are beta blockers. So beta blockers are also critical. They protect the heart from further damage by lowering heart rate and blocking harmful signals from the nervous system. So the benefits of beta blocker is attributed in part to their ability to prevent the changes that occur because of chronic activation of the sympathetic nervous system. And these agents decrease heart rate and inhibit release of renin in the kidneys. In addition, beta blockers prevent the deleterious effects of norepinephrine on the cardiac muscle fibers, decreasing remodeling, hypertrophy, and cell death. 3 beta blockers have shown benefit in HFrEF. Full form is heart failure with reduced ejection fraction. Basically, it is also a type of heart failure. It happens when the heart's lower left chamber, basically also known as left ventricle, doesn't pump blood out to the body as well as it should. So it is sometimes also called as systolic heart failure. So HFrEF, second name is systolic heart failure. So 3 beta blockers are used to benefit in heart failure with reduced ejection fractions, and these are bisoprolol, carvedilol, and long-acting metoprolol succinate. So next are diuretics. Diuretics reduce signs and symptoms of volume overload such as dyspnea on exertion, orthopnea, and peripheral edema. Diuretics decrease plasma volume and subsequently decrease venous return to the heart, that is basically preload. So this decreases cardiac workload and oxygen demand. Diuretics may also decrease afterload by reducing plasma volume, thereby decreasing blood pressure. Loop diuretics are the most commonly used diuretics in heart failure. So they reduce plasma volume, making it easier for the heart to pump. One of the most exciting developments in heart failure treatment is the Angiotensin Receptor-Neprilysin inhibitor. So how do they work? They combine two important actions. Number one is neprilysin inhibition and number two is angiotensin receptor blockade. So number one, neprilysin is an enzyme that breaks down beneficial substances in the body called natriuretic peptides. So these peptides help the body get rid of excess salt in water. They dilate blood vessels and they reduce the buildup of scar tissue in the heart. So by blocking neprilysin, ARNIs increase the levels of these helpful peptides, leading to natriuresis, the excretion of sodium. They also cause vasodilation and they also cause reduced fibrosis in the heart. Number two action is angiotensin receptor blockade. They work by reducing blood pressure and preventing fluid retention. So they block the renin-angiotensin-aldosterone system. So this counteracts the harmful effects of the RAS, such as high blood pressure, increased fluid volume, and the heart muscle thickening. So together these effects reduce the heart workload by lowering blood pressure, decreasing fluid buildup, and preventing further damage to the heart muscles. So the first and most well-known drug in this class is sacubitril/valsartan. Sacubitril/valsartan combines the actions of an angiotensin receptor blocker with neprilysin inhibition. So inhibition of neprilysin results in increased concentration of vasoactive peptides, leading to natriuresis, diuresis, vasodilation, and inhibition of fibrosis, as we already discussed. Together, the combination decreases afterload, preload, and myocardial fibrosis. So this image shows angiotensin receptor-neprilysin inhibitors work by targeting two different mechanisms in heart failure treatments, offering a dual benefits. So the left side of the diagram illustrates the positive effects of neprilysin inhibition. Neprilysin is an enzyme responsible for breaking down natriuretic peptides, which include atrial natriuretic peptide and B-type natriuretic peptide. So these peptides play a critical role in heart function by promoting vasodilation, natriuresis, and reducing cardiac remodeling. So the neprilysin inhibitors block this enzyme, preventing the breakdown of these beneficial peptides. As a result, these peptides continue to work longer in the body, promoting improved blood flow and reduced strain on the heart. So the combined effect leads to vasodilation, reduction in cardiac remodeling, and decrease in the hormones renin and aldosterone, which are involved in fluid retention and blood pressure control. So the right side shows the negative effects of overactivation of the renin-angiotensin-aldosterone system. So the RAS leads to the production of angiotensin II, a hormone that causes vasoconstriction, fluid retention, and cardiac remodeling. So all of which increases the strain on the heart. And angiotensin receptor blockers, ARBs, such as valsartan, block the effects of angiotensin II at the AT1 receptors, reducing vasoconstriction, sodium and water retention, and remodeling. So an ARNI like sacubitril/valsartan combines the effect of neprilysin inhibition and angiotensin receptor blockade. Sacubitril inhibits neprilysin, allowing beneficial natriuretic peptides to stay active. Valsartan blocks the harmful effects of angiotensin II, reducing the adverse effects of RAS activation. Together, these actions result in increased vasodilation, increased sodium excretion, reduced fluid retention, and prevention of further cardiac damage. So this dual approach improves heart function, lowers blood pressure, and reduces the strain on the heart, which is critical for patients with heart failure. Next up, we have a class of drug known as Hyperpolarization-Activated Cyclic Nucleotide-Gated Channel Blockers. So the most well-known drug in this category is ivabradine, which is used specifically to reduce heart rate in patients with heart failure. So how does ivabradine work? Ivabradine selectively inhibits the HCN channels, which are responsible for generating the funny current or F current in the sinoatrial node. So this current is crucial for controlling the heart rate because it sets the pace at which the heart's natural pacemaker fires off electrical signals. By blocking the F current, ivabradine slows down the heart rate without affecting the heart's contractility, blood pressure, or the conduction of electrical signals to the atrioventricular node. This is important because in heart failure patients, a slower heart rate allows the heart more time to fill with blood between beats, which improves overall cardiac output. So that will lead you to think what makes HCN blockers different from other heart rate lowering drugs. So while beta blocker also reduce heart rate, they can sometimes lower blood pressure and contractility, which is not always desirable in certain patients. Ivabradine, however, works specifically on heart rate, making it a useful alternative for patients who cannot tolerate beta blockers due to side effects like low blood pressure. Ivabradine is approved for use in patients with heart failure with reduced ejection fraction who have a heart rate of 70 beats per minute or higher, despite being on maximum doses of beta blockers. So it has been shown to improve symptoms like fatigue and shortness of breath and to reduce hospitalization due to heart failure. However, ivabradine isn't for everyone. It is important to monitor for potential side effects like bradycardia and visual disturbances known as phosphenes, which can occur due to its effects on retinal cells. Next up, we have Vaso and Veno dilators. Dilation of venous blood vessels leads to a decrease in cardiac preload by increasing venous capacitance. Nitrates are commonly used venous dilators to reduce preload for patients with chronic heart failure. Arterial dilators such as hydralazine reduce systemic arteriolar resistance and decrease afterload. So if the patient is intolerant of ACE inhibitors or angiotensin receptor blockers, or if additional vasodilator response is required, a combination of hydralazine and isosorbide dinitrate may be used. Now let's talk about inotropic drugs, which play a crucial role in heart failure treatment, especially for patients with severe or acute heart failure. These drugs work by increasing the contractility of the heart, meaning they make the heart pump stronger, which can help improve blood flow to the body. So how do inotropic drugs work? The force of contraction in the heart muscle is directly related to the amount of calcium inside the heart cells, as we already know. Inotropic drugs increase the amount of free calcium within the heart muscle cells. So by doing this, they enhance the heart's ability to contract more forcefully, which increases cardiac output. There are different types of inotropic agents, including digital glycosides and sympathomimetic inotropes, dopamine, dobutamine, and phosphodiesterase inhibitors, milrinone, and some other drugs as well. We will discuss digital glycosides right now. So digoxin is one of the oldest and most well-known inotropic drugs. It works by inhibiting the sodium-potassium ATPase enzyme, which leads to an increase in intracellular calcium. So this boost in calcium strengthens the contraction of the heart muscles. Digoxin also has another important effect. It increases vagal tone, which slows down the heart rate and reduces oxygen demand. This can be beneficial for patients with atrial fibrillation as it helps control the heart rate. However, digoxin has a narrow therapeutic index, meaning there is a fine line between a therapeutic dose and a toxic dose. Patients need to be closely monitored for signs of digoxin toxicity such as nausea, vomiting, and arrhythmias. So the mechanism of action is elucidated here in three portions. Number one is regulation of cytosolic calcium concentration. Number two is increased contractility of the cardiac muscle, as we already discussed. Number three is neurohormonal inhibition. Although the exact mechanism for this effect has not been elucidated, low-dose digoxin inhibits sympathetic activation with minimal effects on contractility. This effect is the reason a lower serum drug concentration is targeted in heart failure with reduced ejection fraction. So the image represents how digoxin works. Digoxin inhibits the sodium-potassium ATPase pump. So this will lead towards more sodium inside the cell, and the increased sodium disrupts the sodium-calcium exchanger, so calcium stays inside the cell. So more calcium inside the cells improves heart's contractility, helping it pump blood more effectively. So this mechanism is why digoxin is used in heart failure. It strengthens the heart's contraction, helping to increase cardiac output in patients with weakened heart function. So our last and another important treatment option in heart failure, especially in acute cases, is the use of recombinant B-Type-Natriuretic peptide, also known as BNP. One of the main drugs in this category is nezaritide, which mimics the action of the body's natural B-type natriuretic peptide. So what exactly is B-type natriuretic peptide? So BNP is a hormone produced by the heart in response to increased stretching of the heart chambers, which happens when there is too much fluid in the body. So it's part of the body's natural defense mechanism to reduce blood volume, decrease blood pressure, and reduce the heart's workload. So when heart failure becomes severe, the body may not produce enough BNP on its own, which is where recombinant BNP niziretide comes into play. So how does recombinant BNP work? Recombinant BNP works by binding to natriuretic peptide receptors on blood vessels and in the kidneys, and it produces three main effects such as vasodilation, natriuresis, and diuresis. So these effects work together to improve heart function and relieve symptoms like shortness of breath, which is often caused by fluid accumulation in the lungs. So niziretide is typically used in the hospital setting for patients with acute decompensated heart failure. This is when the symptoms of heart failure suddenly get worse. So it's given intravenously, usually when other treatments like diuretics or vasodilators aren't providing enough relief. So when it comes to treating heart failure, the goals of therapy are clear, and each step of treatment plays a critical role in improving both short-term and long-term outcomes for patients. The major goals of treatment in heart failure are to alleviate symptoms and reduce morbidity by reversing or slowing the cardiac and peripheral dysfunctions, and to improve prognosis and reduce mortality. For in-hospital patients, in addition to the above goals, other goals of therapy are to reduce the hospital stay and subsequent readmission, to prevent end organ damage, and to appropriately manage the comorbidities that may contribute to poor prognosis. Another important aspect of heart failure management is understanding how severe the condition is. The New York Heart Association has developed a functional classification that helps healthcare providers assess the extent of heart failure by looking at how much it limits a patient's physical activity. So this classification has 4 classes ranging from mild to severe heart failure that are named as Class 1, Class 2, Class 3, and Class 4. So the class 1, this is the mildest form of heart failure. In this stage, patient experience no symptoms with ordinary physical activity. Their heart failure is present, but it doesn't limit their everyday activities. People in class 1 can still engage in normal activities like walking or climbing stairs without experiencing any discomfort. In class 2, patients are comfortable at rest, but ordinary physical activity like walking a short distance or doing light chores can cause symptoms of heart failure such as fatigue or shortness of breath. While the heart is still functioning well enough to support rest, it struggles with moderate exertion. And for class 3 patients, symptoms are more pronounced. These individuals experience symptoms of heart failure with less than ordinary physical exertion. Even light activities like getting dressed or walking a short distance may cause fatigue, shortness of breath, or palpitations. Their physical activity is severely limited. And for class 4, this is the most severe form of heart failure. Class 4 patients are unable to carry any physical activity without experiencing symptoms. Even at rest, they may feel uncomfortable and display symptoms of heart failure such as shortness of breath, swelling, and fatigue. This class reflects a very advanced end stage of heart failure where the heart struggles to support even basic bodily functions. So to wrap it all up, heart failure is a serious condition, but with the right understanding, treatment, and lifestyle changes, it can be managed effectively. Thank you for joining me today on Pill Talk. If you found this video helpful, don't forget to give it a thumbs up and subscribe for more health-related insights. And as always, if you have any questions or topics you would like me to cover, drop them in the comments below. Stay informed and stay healthy, and I'll see you in the next video.